So, Dr. Sandler,
Sir.
you can cure depression and anxiety.
Yeah.
And when you're
Only
talking-
I just gave a little talk about what makes it
Right.
a wall psychology.
Welcome back to Psychobabble. Last time Steve and I talked about case of Anna O. And I thought that it'll be good to discuss it a little bit more because towards the end, Steve, you said that actually Anna O became very sick after Breuer had thought that he had cured her, right?
This is what Freud told to a couple of colleagues years later, that
Uh-huh.
she either wasn't completely well at the end of therapy or she relapsed. In either case, she didn't do that well.
Yeah.
Had a great career as a social worker, but she had a lot of problems.
So that got me thinking that, well, Steve says that he cures people, and is this, happening with his cases too? So I just wanted to bring it up and see what your thoughts were on that. That sometimes people might think that the patient is cured, but you might not.
I was afraid he was going to do this. You've been challenging me all along for maybe the past year after I told you about a few cases that I thought were very successful cases of so-called treatment-resistant depression, like prolonged depression hadn't succeeded in other treatments. And you said, are you saying you're curing these people? And I said, well, yeah. And since then you've been challenging me, which is good. It makes me think about what I'm doing and what we're all doing.
Yes, and the reason I keep challenging it, and that one of my motivations in this whole psychobabble thing is that that some of these patients, who get labeled as treatment resistant, and that means we don't know what to do. Maybe this is what we need to do, what Steve is doing. So
In some cases, I think that, but
yeah. So yeah.
So you're asking, are my successful cases turning out like Anna O in the long run, basically? So there's two questions really here. How do we know that a patient is well enough to stop therapy? And then how do we know that he or she is going to stay well? Right? And I'd like to address the first. When somebody comes in and says, I'm feeling better and better, then I start to think maybe we're done. Whether it's panic or relationship problems or depression, whatever the problem was. And so I will think about our first session, and I'll do a little checklist in my head. You came in with depression. Are you depressed now? No. Great. You also had an occasional panic attack. Are you having panic? You had some problems getting along with your wife. How's the relationship with your wife? And I always check self-esteem, whether they brought it up or not, because so many people have problems with self-esteem, and they're secretly walking around thinking, I'm so stupid and I'm so bad.
Yeah.
So I have a little checklist in my head. And then I'll ask about how do you feel about your parents, because the vast majority of my patients had problems growing up in family relationships. And I want to know, are you at peace now with the fact your father had a bad temper and hurt you like that? And are you at peace with the fact your mother seemed to favor your older sister? Are you at peace with your parents? Or is there something else that's rattling you about that? So I have this checklist, and then if that all looks good and the patient and I both feel like we're done, okay, we'll stop. And then how do I know that they'll stay well? I tell everybody on the way out the door, I want to see you back in 6 months. And I do that at least once, if not 2 or 3 times, to say, let's, again, just do a check and make sure we didn't miss anything.
Yeah. So there's a follow-up, 6 months to a year, most, and you see that that has usually it is held, for those people.
Often, yeah. I've had some patients come back or call me before the 6 month and say, I'm in trouble again. And then I think, darn, I thought we had resolved this, but I'm happy they're calling me instead of going elsewhere.
Right.
Because it gives me an opportunity to say, well, what did we miss? What can we do better?
Right. Yeah.
I can become better.
Yeah. Yeah.
And help them.
Yeah. 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 That's good. And so, in psychiatry, they have to have these 100 cases that you've seen, and they have a 5-year follow-up or 1 year. Usually they don't go 5 years. It's so hard to do those studies.
Right.
But 1 year, I think, is usually for a pharmacological thing that how many people relapsed, after getting better. So, so we don't have that kind of a data for you.
No.
Right?
No, I'm not a researcher, and I'm not.
Yeah, you're not interested in that, right?
Yeah.
Yeah. What I think is that in generally in medicine, when we really don't know what's going on, like in the cancer, in many cases of cancer, or in diabetes, we go with this statistical data, that things got better. Now let's see, did they stay better? Because we didn't know that actually what was going on, the final, as opposed to an infectious disease, if you have bacterial pneumonia, you're cured. You're done. Yeah, there's no 5 year or 10 year, because we know exactly the problem.
Yes.
And we know we have solved it because the bacteria is gone, the infection is gone.
Right.
So is it something like that what you're talking about? That like those generally, we have this quite a lot of skeptical view of our understanding that we really don't know what is depression, and if they got better.
Well, that's the problem.
That is the problem, right?
Right. It's not as simple as, so you have a bacterial pneumonia, we cured it, have a nice day.
Right.
And that's it. We can't seem to agree on what is depression and what is anxiety and how much is genetic, even though we've talked about this, and it's clearly not all genes. But without having a clear idea of what caused it, and with the understanding that some people may have more, say, depression genes than others, and we can't measure that yet.
Yes.
We just do the best we can, and then we do a 6-month follow-up and see how things came out.
Yeah.
It would be nice if we could be more scientific, though. Certainly there's been people looking at this off and on for decades. Is there a marker, a blood test marker, that would correlate well with depression? People have looked at blood tests as markers of stress, PTSD. They've looked at inflammation, because inflammation goes with depression. Could we do a blood test at the beginning of therapy and then at the end and say, you're done, you're cured? Or could we look at heart rate variability? Because of the little variation between the heart rate when you breathe in and breathe out, that is altered in depression and probably other conditions as well. It would be nice if we could get that scientific, but we're not there yet.
We are not there. We were not there yet in Freud's time, more than 100 years back, and we are not there yet.
Still not there yet. Right.
So this talks about the difficulty of this whole problem, the complexity of what we are dealing with. Like when you think that you have at least that you, in some cases, that you have cured someone, which means that you are pretty confident about your understanding of the problem. Unlike, we don't know what, we just go by statistics that, Paxil had 70% improvement and Effexor had 65%.
And we barely know what to measure.
And we barely know what they're doing. We just know that they're doing something. So this is different, that because it's quite many steps ahead in saying that I understand what is going on.
Right.
And that's usually the more psychologically.
Right. Well, I have a theoretical foundation, of course, some of Freud's best ideas and the century of people who followed him, and things that we can talk about down the road in terms of memory theory, holding bad memories, and can we change the way you think about things, not just let out some feelings. So I have a theoretical foundation, which I think is important.
So I think we can conclude at that, that this is a very complex topic. We can sit here and talk for hours, but I think hopefully we gave a little good idea as to what we are talking about.
Yeah, and where we are in the field.
Where we are in the field.
We can still assess at the end of therapy where we're at. We can do a 6-month and a 12-month follow-up and see where the patient is. And there are people studying, are there physiological markers we could use? And I think one day we'll be there. Then we can talk again more scientifically.
All right. So we'll see you next week.
See you then.
I want to get